Hello, my name is Maria, and today I'll be reviewing pain assessment and management, a situational analysis. Surgeries are a crucial healthcare service aimed to reduce risk of death and disability among millions worldwide each year. In 2017 to 2018, Australian hospitals received 352,000 emergency surgical admissions. Common surgeries performed were appendicitis, hip fractures, and acute myocardial infarctions. The most common population groups includes males, the elderly, people living in remote areas, as well as Aboriginal and Torres Strait Islander people. There were over 2.2 million elective admissions, mostly consisting of females, elderly, and regional dwellers, generally for cataract, malignant skin lesions, and other retinal disorders. Although life saving, surgery is also associated with potential adverse effects, which frequently includes pain. Pain is an unpleasant multidimensional experience subjective to individuals. Acute pain occurs following tissue injury, during operations, and should resolve during the healing process. Pain often results in prolonged hospital stays, increased time to discharge, development of chronic pain, readmission, and time before ambulation. Poorly controlled pain post-operatively can have a negative psychological effect, such as impaired sleep, demoralization, and anxiety. Therefore, effective pain assessment and timely response are crucial for the alleviation and management. Several scoring and assessment tools are currently in practice to assess acute pain. The gold standard for assessment is patient's self-report of pain, including the verbal rating scale, where patients are able to describe their pain quality and severity. Numerical scales such as the 10-point pain assessment, where 0 is no pain and 10 is the worst pain imaginable, are routinely measured post-operatively. The visual analog scale is recommended in children, patients with neurological conditions, or individuals with speech deficit by using visual descriptors such as facial expressions, grimacing, or clenching. The PQRST pain assessment is a great tool to allow the whole experience to be evaluated. Post-operative pain may not only be isolated to the surgical site, it can also be caused by underlying issues. These scales are reliable and valid sources to monitor pain. They are easy to use and have a high compliance in patients. Current best practice pain management techniques includes multimodal analgesia, patient-controlled analgesia, and various non-pharmacological approaches. Multimodal analgesia, introduced in 1993, involves the combined use of opioids, non-steroidal anti-inflammatory drugs, and adjuvants, such as antidepressants and muscle relaxants. This technique targets different mechanisms of action in the peripheral and central nervous system, thus producing a greater synergistic effect. Patient-controlled analgesia (PCA) is useful in conscious patients who understands the instructions to use the machine, allowing self-dosing, which are much more preferred by patients. However, side effects, pain scores, dosage of opioids, and length of hospital stay were much similar to other approaches. Non-pharmacological interventions can be used throughout the perioperative phase. They are often cost-effective and easy to implement. Techniques include cognitive behavioral therapy, which aims to improve mental health through changes in behavior and improving emotional regulations. Distraction techniques are used to divert focus of pain from patients. Therapies include music, canine, aroma, and have shown the greatest benefit in patients with anxiety. It can be used as self-management programs and less concerned with side effects of traditional pharmacotherapy. Pain assessment and management still remains a concern in which persistent pain may develop into severe chronic pain in 2 to 10% of these patients. Some barriers identified by an article by Delta shows nurses were unfamiliar with non-verbal assessment scales due to insufficient training in school and workplace. Thus, nurses were often solely relying on patients' self-report as source of evaluating pain. Health professionals often rely on self-reports of patients. Nonetheless, pain in patient groups that are unable to self-report are underestimated. Patients with lowered levels of consciousness were assumed to have no sense of pain or that they are under sedatives and therefore not needing to conduct a pain assessment. Personal beliefs of patients' pain were another factor that influenced adequate pain management. Healthcare professionals may only rate pain through visual observations and the changing hemodynamics, and may be reluctant to fully trust patients' self-report due to past experiences of ineffectiveness. Less experienced nurses showed main focus on acquiring skills such as working with equipment, new procedures, or dose calculations. Inadequate nurse-physician interaction regarding patients' pain, thus unable to effectively provide patient-centered management strategies. Inattention to patients' pain whilst focused on several complications such as fever, as well as the absence of a standardized non-verbal assessment for individuals unable to communicate were another inhibitor. These strategies and recommendations may improve pain assessment and management and will help prevent the resulting harmful effects. Poor communication were identified as a major source of medical error, especially prominent in patient handoffs. Standardization of SBI handover allows the delivery of comprehensive information efficiently. It allows preparation of the sender and receiver to process information in a concise manner. The involvement of the acute pain service team has shown significant decrease in patients' postoperative pain rating, as shown by studies. The team is dedicated day-to-day management of patients with acute pain, providing appropriate care and monitoring, person-centered as well as managing in-services for the medical and nursing staff with up-to-date studies. Preoperative education evaluation is vital to successful pain management postoperatively. It is involving the patient in a shared decision making, provided with relevant information so that the most appropriate management can be prescribed. High quality educational materials should be given to enable patients and the family to participate fully in decisions regarding the treatment. Postoperative pain is a continual issue in healthcare. However, by following the guidelines and best practices, we can effectively tackle this issue.